I'm sure a lot of you know Damian. He's an amazing cornea specialist and refractive surgeon, a wealth of experience managing ocular surface diseases, including a lot of work about ocular surface allergic eye disease. Now, Damian, are you able to share slides if you manage to do that?
It says host disabled attendee screen sharing. So,
okay, we'll let the host allow you to share screens. So just to say a couple of things about Damian. He's a consultant ophthalmologist at Queen Victoria Hospital in East Grinstead, a high flyer in the world of cornea and refractive surgery and ocular surface disease. If you listen to Damian in the past, you agree that he's one of the amazing speakers. He keeps you entertained throughout the talk, and his talks always full of knowledge and tips to help you manage the disease. I'm just waiting for Damian to see if he managed to share his screen. If you have any questions, please, I'm sure there will be a lot of questions, but just write it on the chat on the bottom. We'll make sure that we answer the questions at the end. If we can't for any reason, we'll promise we'll try to pass the questions to Damian. I'm sure he'll be kind enough to answer those questions. So without any further delay, now we can see your screen, Damian.
Wonderful. That's the most stressed I've been for a long time.
Great, great. Good. So welcome to SI webinar, Damian. Please, the microphone with you, and you're sharing your screen fine now. Thank you.
Good evening to everybody. Thank you for joining us. Thank you for Samir's lovely introduction. None of it was true, but there you go. And we will be talking tonight about allergic eye diseases. I'm from the Queen Victoria Hospital in East Grinstead, and I'll give you an overview this evening. So allergy, what is it? Well, allergy is an abnormal response, an abnormal immune response to an otherwise harmless substance in the environment. It is a very common problem, particularly in primary care, where over £900 million is spent every year, which is a huge amount in the hospital budget. About 20% of people, prevalence in the general population have allergy of some sort. And what has caused this sort of increase in allergy that we see in the community? Is it family history? Is it a vitamin D issue? Is it due to people having a cleaner environment, and so their immune system is stimulated less when they're young? Is it due to late weaning? All of these have been propagated as possible reasons, but without particular proof. In European studies, up to a third of the general population, as I say, have had ocular allergies. Most of those are either seasonal allergic or perennial allergic forms of the disease. The old classification, which we learnt when we were at medical school, the Gell and Coombs classification, is now really superseded, but it enables at least us to have a classification in our mind as to how the processes of ocular allergy works. And the commonest types are type 1, so the antigen in the environment stimulates IgE production. There's a second antigen which cross-reacts the IgE attached to a mast cell, which causes degranulation based on a calcium pump. There's mediator release, including histamine and many other vasoactive factors and inflammatory factors, which leads to an immediate allergic response. And that's a common mechanism in seasonal allergic, perennial allergic, atopic, and vernal keratoconjunctivitis. The types 2 and type 3, we don't really need to deal with today. But type 4, which is a cell-based immunity, is common still in vernal and atopic. But the point is that in contact dermatitis, our 5th type of ocular allergy, which we deal with commonly, it is not an IgE mediated issue. And that's important for the tests as we go through them later on in this talk. I think it's always good to go back to the basics in any condition that we are discussing. And the primary issue in ocular allergy is the conjunctiva. The conjunctiva is different from the cornea. Its structure is different. It's got a multi-layered epithelium, stratified, non-keratinized. It contains goblet cells producing mucus. The junctions are not tight between the conjunctival epithelium. There's an underlying substantia propria with blood vessels and a fibrous reticular structure underneath the conjunctiva. You can see the multi-layered on the right-hand side. You can see the cross-section of the conjunctiva there with the multi-layered epithelium. Now the conjunctiva, just for my own purposes, runs from the meibomian gland orifice along the back of the tarsus where it's firmly attached, which is different to the bulbocond where it's more loosely attached. There are folds within the fornix, and then it stops at the limbus where it has a firm attachment with the tenons underneath. Now that's important for us to remember when we look at the clinical signs of ocular allergy. So to remember that the conjunctiva has got blood vessels, that it's firmly attached on the tarsus, so its appearance will be different from the bulbar changes that we see in allergy. The primary clinical signs that we see in ocular allergy are papillae, which are on the left-hand side, and follicles, which we see on the right-hand side. On the left-hand side at the bottom, you can see large giant papillae, which can be differentiated because they are vascular with a central red core to the enlargement. And if you look at the histology in the top left-hand side, you can see a vascular response on the histology. So there's a hyperproliferative epithelium with a central vascular core, which extravasates inflammatory mediators, giving that papillary morphology phenotype to our clinical signs. On the right-hand side, at the bottom, we can see follicles. Follicles are pale, they're lymphoid tissue, so they push the vascular tissue to the side. So the raised area is pale and it's redder at the base. And if we look at the top right-hand histology slide, you can see that these look almost like germinal centers because they are stimulating the conjunctival associated lymphoid tissue. So you see raised follicles, so it's more of a lymphoid response. And these are more indicative of seasonal allergic, perennial allergic, as opposed to vernal and atopic keratoconjunctivitis, in which you see more papillae and giant papillae. The classification of ocular allergy basically breaks down into 6 types. The more serious types are atopic keratoconjunctivitis and vernal keratoconjunctivitis, in as much as that they have visually significant side effects or visually damaging side effects. Perennial allergic and seasonal allergic are more common, but have more morbidity attached. Contact blepharoconjunctivitis affects the eyelid margins and is not an IgE-mediated disease. I've included giant papillary conjunctivitis, which is not really an allergy at all. It's a response to a chronic irritation like a corneal suture or a trabeculectomy bleb, but can be confused with those. You can see on the pictures on the top right-hand side, cobblestone papillae, so giant papillae that have expanded, broken their fibrous septa to become even larger, and trantas dots, which are degenerate conjunctiva with IgE at the superior edge of those. What common symptoms do we see in ocular allergy, and how can they help us differentiate which of that classification is affected? Well, redness is common to all conjunctivitis and is no more common really in ocular allergy compared to viral or bacterial conjunctivitis. In fact, normally the redness is slighter than in bacterial or viral causes. A purulent discharge should be a warning sign that this is not ocular allergy that you're dealing with. That would be very rare. You're looking at a different problem if you're getting a purulent discharge. Mucus discharge is more common, but still a minority symptom in ocular allergy. Foreign body sensation is in about 50% of patients with an ocular allergy, but again, it should signal to you that perhaps you're looking for a different cause rather than an ocular allergy. Watery discharge is fairly common, but the symptom without doubt that we're looking for is ocular itch. If you don't have ocular itch, then you need to be thinking that this may not be an ocular allergy at all. Whenever I'm dealing with any problem in the clinic, what I'm at the back of my mind is I'm always worried, like everybody else as a doctor, and what keeps us awake at night is the fact that we might have got it wrong. And therefore, I'm always looking out for warning signs as to why this is not what I think it is. So things that would be atypical in an ocular allergy are that it's unilateral. So ocular allergy is usually bilateral. A foreign body sensation is uncommon. Pain is uncommon. So discomfort, itch, common. Pain itself, uncommon. Purulent discharge, uncommon. Lid margin disease, uncommon. Elderly onset, uncommon. If you get any of these, then you need to look at other causes such as tear film dysfunction, evaporative dry eye, hyposecretive dry eye, blepharitis, an infectious conjunctivitis, a mechanical or toxic conjunctivitis, and in the elderly, particularly an autoimmune conjunctivitis or a masquerade syndrome like a conjunctival carcinoma or sebaceous cell carcinoma. Now, breaking down the different subsets of ocular allergy. So first of all, atopic. What's common in atopic? Well, atopic keratoconjunctivitis are usually people who are slightly older, so in their late teens or 20s or above. They've got a history of asthma and eczema already in over 90% of cases. They will have lid changes, so they've got eczema on the lids. And the cell type of the skin and the ocular surface embryologically is the same. So they will get inflammation on the ocular surface as they do on the lid margin. And that gives a sort of flexural change to the lid margin. It looks thickened, both on the upper and the lower lid. There'll be meibomian gland destruction, and that causes ocular surface inflammation. There's generally no seasonal variation. They're slightly older than the contrasting vernal keratoconjunctivitis. They've nearly always got an atopic history. If they haven't got an atopic history, then you should severely question whether this is atopic keratoconjunctivitis. They get a lot of itch, a lot of tearing, a lot of photophobia, and mucus discharge. The underlying pathogenesis is a B cell problem, and they will have IgE raised. The skin changes we've talked about. They'll also have something called Denny's lines, which the flexural changes in the medial lower lid will be folded because the lids are thickened and swollen. The conjunctiva will be swollen. There'll be some fibrosis on the tarsal plate in a sort of honeycomb pattern. You're more likely to see trantus dots, which we saw on the slide before. They are more prone to ectasia because most likely due to the mechanical stimulation and due to the ongoing inflammation. They get more herpes simplex virus. They're more likely to get epithelial erosions, which will break down into ulceration, and more likely to get neovascularization within the cornea. Because the lens capsule is the same embryological route as the ocular surface, they're more likely to get cataracts on the anterior surface or from steroid use, cataract from steroid use. And they're also more likely to get retinal detachment. So it's wise to do a documented retinal examination. The conjunctiva is papillary. So you can get follicles, that will be rare. You're more likely to get papillae and lots of papillae and fibrotic changes over time. You can see that the conjunctiva is translucent and raised. There's some swelling there due to extravasation from the papillary response. You see punctate keratopathy. Now that punctate keratopathy is due to the destruction of the meibomian glands and to the toxins released by the ocular surface. That can break down into frank ulceration. It stimulates neovascularization of the limbus and you get limbus breakdown. You can see the honeycomb reticular fibrosis from the recurrent attacks of inflammation on the tarsal plate on this photograph. Often if you turn over the top lid after the atopic keratoconjunctivitis has burnt out over time, you can see what looks like a pseudo-Alts line. Alts line you see in chlamydia and trachoma, but you can see something very similar in chronic atopes as well over time, and that can affect ongoing management and affect their ocular surface, and that can be dealt with by mucous membrane grafts when it's severe. There are vision-threatening effects from atopic keratoconjunctivitis. You can get ulceration, those can be infective. You can get neovascularization with extravasation of lipid, causing lipid keratopathy, and it is a condition which needs to be treated expediently. Atopes are not uncommonly requiring penetrating keratoplasty or deep lamellar keratoplasty. They will need this either due to visually effective scars or to associated keratoconjunctivitis. They are a much more difficult group to deal with because anyone with ocular surface inflammation is more prone to penetrating graft failure, and the management of that is a lecture in itself. They'll often need tarsorrhaphies to help the ocular surface heal after penetrating keratoplasty and long-term immunosuppression. If you look with a confocal microscope at the papillae, you can see the papillary reaction on the left-hand side. In the middle, you can see the inflammatory cells which are suffusing the subconjunctival area. And on the right side, you can see a circular structure, which is a blood vessel with the eosinophils extravasating from that blood vessel and filling the subconjunctival space, creating the inflammatory issue. If you investigate atopic keratoconjunctivitis, you'll find that the serum IgE is raised. They will get symblepharon, but there are certain issues there, particularly if you saw an older person who had atopic keratoconjunctivitis and used symblepharon, you would worry that they may have also OCP, and there have been cases described of people with atopic and OCP, ocular cicatricial pemphigoid, so a biopsy would be indicated in that case. I would tend to do corneal tomography or OCT on atopes because they are more likely to get keratoconus, and that may need collagen cross-linking at an early stage, and document that the retina is healthy with a retinal photograph. Beware of those young people who have got really bad skin problems, who have been put on immunosuppression at a young age, systemic immunosuppression. They are more liable to tumor formation on the ocular surface, including squamous cell carcinoma, which this poor young fellow had. Initially, you might see just moderate limbal changes, but that can turn into CIN and squamous cell later on. So just have that in mind. Now, vernal keratoconjunctivitis is a similar condition, but with distinct differences. It's often in a younger age group, so it would not be found in somebody under 3, but it often burns out after puberty. It's more common in males and females, but it doesn't mean that you can't get it in females. You do get itch and tearing and photophobia, and that does tend to be continuous, but with acute exacerbations. You will get a seasonal variation. It's more common in the spring and early summer. Only 40% have atopic history with rhinitis, eczema, asthma. And this is a T helper 2 receptor issue. There is a sex hormone proclivity, which increases the veracity of the disease. There's genetic influences as described by different presentations in different populations. So Black British, Africans will have more limbal disease than Caucasians, who are more likely to have lid disease. And there are different prevalences in different populations. The clinical features of vernal are that the lid skin is normal. They do not get atopic changes on the lid skin like atopic keratoconjunctivitis. They may get ptosis due to the giant papillary changes underneath the lid. The conjunctiva is swollen. The tarsal plates show giant papillae. The limbal changes are similar to atopic, but they can be more vigorous in dark-skinned people. The Cornea will show punctate erosions and superficial punctate changes more commonly. You are more prone to ulcers in a shield pattern in the superior cornea, and those ulcers will be layered with mucus, preventing easy healing. You're more likely to get neovascularization, and you will still get ectasia. They are prone to cataract, but less so than atopes, and those cataracts are usually due to steroid effects. Vernal is a vision-threatening condition in young children often. It is an emergency. Those ulcers are normally superior cornea, and they will leave scars which will affect the visual development of the child. You will get neovascularization with extravasation of lipid. The lid changes will often be more severe than with atopic on the tarsal plate, though the treatment of that can be either supratarsal injections of steroids, which can be helpful, contact lens to prevent the physical effect of the giant papillae on the cornea, or I would suggest a mucous membrane graft in some severely affected patients. I'm less keen on either cryotherapy or surgical removal and leaving the area bare, because that will often scar and cause buckling of the top lid. The inferior lid is less affected. You will still see papillary changes, but not as advanced and aggressive as the superior lid. And you will get fibrosis just as on the edge of the eyelid margin here. You can see this is the everted lid. The superior everted lid has got papillary changes, but by the lid margin, you can see again fibrotic changes. The inferior lid less affected, and cataract due to steroid effects. The superior lid mainly causes the corneal changes. So you can see on this slide the fluorescein changes superiorly on the cornea with punctate erosions, but also raised areas where mucus is attached to those areas of deficient corneal epithelium. On the tarsal plate, occasionally you'll see the odd follicle within the mass of papillae, and you may also get limbal changes like this trantus dot. You can see a raised area with degenerate eosinophils above that. In African people, the limbal type of vernal keratoconjunctivitis conjunctivitis is much more severe and much more common, and if you work in metropolitan areas, you may see that more commonly. Occasionally, that can be mistaken for tumour or can be very, very severe, as in this slide here. The vernal clinical features, so these ulcers are vision threatening and should be treated as an emergency. The management of those is to perform microscopy, culture and scrape the ulcer for two reasons. One is to debride the mucus which attaches to the base of the ulcer and prevents healing. And the second is to exclude that there's not an indolent infection such as Staph aureus. After that, my preferred management would be to fill the ulcer with amniotic membrane, with inlays and then an overlay. Preferably I would use fibrin glue to do that so that the child doesn't have to go back to theatre to have the suture removed, and it's less damaging to the ocular surface. I then put a bandage contact lens over the AMT and deal with any lid problem, which is very important. If you don't deal with the lid, then the ulcer will recur, and that will be a big problem. You can see here the lid problem is causing the corneal problem. So if you avert the lid, if you don't deal with those at the acute time, you're just going to get a recurrence in the future. Vernal, again, leads to deep lamellar keratoplasty due to scars or keratoconus. Again, the prognosis for these compared to a standard keratoconic patient is less good, and they will likely have recurrences of neovascularization due to the ongoing inflammation. Vernal investigation. Well, you can do confocal microscopy. It's not helpful except from a research point of view. You can see the swollen papillae in the bottom right with eosinophils, which are within the subconjunctival space. And these are high compared to atopic, so they help differentiate on that point of view. You can do a skin test, which we'll talk about later, which is positive in 50% of patients. So the more common but less visually affecting conditions are seasonal and perennial allergic conjunctivitis, and they're differentiated by the amount of time that you would suffer from those. So for seasonal, you would expect them during distinct seasons when you're allergic to a particular grass or a particular tree pollen. Perennial would tend to be all year round, and you're affected by something that's ubiquitous in the environment, usually house dust mite, but it can be other allergens. Seasonal allergic is a type 1 hypersensitivity. You'll remember from the Gell and Coombs slide that this is an IgE mediated issue after mast cell degranulation. It can be associated with hay fever and asthma, and is prevalent in children and young adults. So the allergen causes immunoglobulin E production, which attach to mast cells. The mast cells degranulate under a calcium channel mechanism, releasing histamines and other vasoactive substances, which create the itch by stimulating the nerve endings and creating vasodilation of blood vessels, swelling and inflammation. Pollen is common throughout the UK. The common reasons for it are grass pollens. I mean, there is grass everywhere, it's ubiquitous. Nettle plants and birch trees are the commonest reasons for seasonal allergic. The pollen calendar used to be that you would get peaks in April, May, June. That tends to be much longer nowadays because we get a wet and warm climate as opposed to distinct climate variation, which we had in the past. But certainly you should see a peak around June or July in grass pollens, which are the commonest issue. So 1 in 4 in the UK suffer from seasonal or perennial allergic. There are 18 million people in the UK. It counts for about 1 in 8 people who go to the GP with allergic conjunctivitis. Most of those hay fever sufferers are allergic to grass pollen. There are 150 different types of grass pollen, and 20% of pollen sufferers are allergic to tree pollens. So is that useful? How do we differentiate out those? Well, in the NICE guidelines, it suggests that allergic patients should have patch testing. Now, patch testing is when you attach the allergen to the unbroken skin. That's not IgE-mediated allergy, so it's only really useful in contact blepharoconjunctivitis, by which I mean somebody who's allergic to maybe nickel in their jewelry or cosmetics that they're applying directly to the skin. It's not really that helpful in atopic or vernal or seasonal allergic keratoconjunctivitis. But if you've got a patient with allergic blepharoconjunctivitis, sending off to the dermatologist specifically for patch testing will be useful. Now, skin prick test is different. It's when the allergen is applied through the skin into the subdermal area. If you get a positive test, then you'll get a red raised area. We've all seen this, and that's a skin prick test. So if you get a positive skin prick test, you often get more than one positive skin prick test to a particular allergen. It then may be worthwhile doing a serum allergen specific IgE to work out whether they've got a more systemic allergic response to those allergens. You can do then a tear microassay specific IgE to see whether the conjunctiva reacts to that allergen. If you compare the serum response to the tear response, you can work out in a multi-allergic person what it's most likely that they're reacting to on the ocular surface. And in studies, you can also do conjunctival allergen provocation test in a similar manner. So for diagnostics, you can measure using capillary action. So you've seen capillary pipettes. You can take tear samples and do cytology. You can measure IgE levels, tryptase, histamine, eosinophilic cationic protein. But is that useful? Not really, because no single factor or test is a specific disease marker. So those are useful in research, but not clinically to differentiate. We can do confocal microscopy. You can see in the top right-hand side a corneal nerve which runs down the center of the confocal microscopy with dendritic cells either side. So you get an upregulation of dendritic cells. You can see inflammatory cells within the cornea. So there's a corneal response to ocular surface allergy, and you can measure the response to treatment with confocal microscopy over time. Interferometry is useful because you get an increase in lipid layer in seasonal allergic. Meibography can be useful in atopic keratoconjunctivitis because you will get destruction of meibomian glands. And OCT and topography, particularly in atopes and vernal, is useful to check that there is no associated keratoconus. So we now know how to diagnose the different types of allergic conjunctivitis, and we know the vision-threatening emergencies in allergic conjunctivitis, but how do we treat allergic conjunctivitis? Now, both in general practice and in secondary care, it has always tended to be treating the symptoms of allergy rather than treating the allergy itself. Now, there are immunotherapies out there to treat the allergic response. Now, immunotherapy is a treatment that immunologists can perform for us, in which the body's immune system is diverted by a gradual exposure to the allergic response if you've got an IgE mediated allergic response. And you can do that with either subcutaneous immunotherapy or SCIT, or sublingual immunotherapy, SLIT. And this is well proven now. There are over 100 RCTs in favor, particularly in grass pollen allergies, of these treatments, which can alter the allergic response, and compared to things like oral antihistamines are much better. 11 RCTs were equivocal, but none that have shown that they have not worked. So if you do have a positive skin prick test and an IgE response, it's worth referring to an immunologist to consider immunotherapy. For severe allergic response, so this is not first line, a short course of steroids in vision threatening conditions can be useful. Now, I would mean for no more than a week's time to really get the allergic response under control. In the longer term, particularly for atopic individuals, cyclosporine can be useful and can have a dramatic effect. You might need to institute that with a dermatologist or rheumatologist. And montelukast, which is a leukotriene inhibitor, has been shown to be not quite as good as an oral antihistamine, but when combined with an oral antihistamine, is a good steroid-sparing agent, particularly for children. I use supratarsal triamcinolone a lot in people who've got severe ocular allergy like atopic or vernal, particularly vision-threatening conditions. And there are biologics out there which can alter the effect and control the severe allergic issues. So omalizumab, which is licensed or is not licensed, but has been used for vernal keratoconjunctivitis, can be useful. It's approved, unfortunately, for urticaria, but it has been used for vernal. And in those cases in which it's been very difficult to control, that can be something that you could consider for your patients. And for atopic patients, dupilumab, which is for atopic keratoconjunctivitis. It's licensed for eczema and atopes. On the downside, it does have a side effect in some patients of subconjunctival fibrosis, so it may not be useful in those that have already got symblepharon formation. Now, the common treatments for allergic conjunctivitis we often miss. And the first one is to avoid the allergen in the first place. And just simple advice can often be very helpful. So if you're allergic to grass pollens or tree pollens in the environment, then obviously remove as much as you can from around the house. During the months when the pollen is in the air, close the windows. Don't have the air conditioning on in the car. Get the children to change their clothes after they come back from school, because the pollen is going to be attached to the clothes. Change the bedding much more frequently during the week, because the bedding will have pollens on and dust mites. When they come back from school in the morning and when they go to school in the morning, have a shower to wash the pollens off themselves. All of these are simple things, but often doctors don't transmit them to the patient and they don't think of them themselves. Lubricants to wash the allergens off the surface of the eye, particularly if they're cool, can be very useful. And cold compresses during an acute exacerbation to decrease the inflammatory response. Lid hygiene to remove as much pollen and allergen along the ocular surface margin can be useful as well. And it doesn't really matter which lid hygiene or lubricant you use, but preservative-free obviously is better. You don't want to stimulate the inflammatory response anymore. So we talked about avoidance, we've talked about lubricants and cold compresses and lid hygienes. Patients can get vasoconstrictors and combined vasoconstrictors and antihistamines over the counter, such as this one, or off the internet nowadays. They can be useful for the redness, so they will decrease the unpleasant side effect of having red eye, but they are useless really for the itch, and patients will get a pupil mydriasis and they will get tachyphylaxis over about 5 to 7 days, and sometimes a secondary allergic response to these with a follicular change. So you need to find out whether the patient has been using these and preferably stop them. Mast cell stabilizers. Mast cell stabilizers are the commonest drugs used in primary care, despite no evidence that they work on conjunctival mast cells in humans. They work by preventing the attachment of immunoglobulin to the mast cell and preventing the mast cell from degranulating via a calcium channel blocking mechanism. If you look at the BNF, you'll see they're better at preventing the signs than they are at actually treating the signs. So if a patient turns up and has got severe itchy eyes, if you give them a mast cell stabilizer, they complain that nothing happens but that the drop stings. And that's because they don't have any effect for about 5 days, and their maximum benefit is after about 2 weeks. So the mast cell stabilizer is really useless as a treatment, only as a preventative agent. They can't be used in contact lens wearers, and they're often not licensed in young children, and they can be up to 4 times a day, which can be prohibitive for kids when they're at school. And as I say, they often get burning and stinging, so patients generally aren't keen to use sodium chromoglycate because they don't get that immediate effect. They have to use them frequently, and they sting when they go in. That's common for nidocromil, which you can use in 6-year-olds, which also has the side effect of a horrible taste. So in general, mast cell stabilizers by themselves are useless rather. Antihistamines. Antihistamines reduce the effect of the histamine released from the degranulated mast cell, but there are different histamine receptors, 1 to 4, I think. We're only interested in receptor number 1 in the conjunctiva. Most antihistamines are competitive receptor antagonists, meaning that they compete for the histamine receptor site. So if there's more antihistamine in the system, it will displace the histamine from the receptor, but if there's more histamine, it will displace the antihistamine from the receptor site. So they don't always work. So if we look at this graphic, the histamine attaches to a receptor and then produces the allergic reaction. When we apply the drug, it competes for the receptor site and blocks histamine from having an effect, but it still has some effect. And if the histamine is particularly vigorously released, it will displace the antihistamine, which is often why both of these medicines are used in combination to have a dual effect, so that they affect on stopping the mast cell from degranulating, and they also stop the histamine receptor site. So a dual effect, having a greater effect. With ketotifen, it also has an effect on eosinophil production, so potentially a tertiary effect also. There are two main dual action combination drops available on the market: opatanol, which is or isn't available at any one time, a selective H1 receptor antagonist and inhibitor of histamine release from mast cells, and ketotifen, which is a receptor antagonist, inhibits histamine release, and also has activity on the activity and degranulation of eosinophils. But these do have side effects. Again, mainly irritation, stinging, dry eye, visual disturbances, and sometimes taste disturbances as well. If you're going to choose any to start with, I would often start with ketofor because it's preservative-free, as opposed to opatanol, which has got preservatives in it. But it has to be avoided in those who are at risk of angle closure. So you may need to do a peripheral iridotomy on those that are at risk. So you might need to do an OCT of the angle initially to document that. Can't be used as soft contact lenses and can't be used in breastfeeding or pregnant ladies. What are the evidence that any of these things work in seasonal and perennial allergic conjunctivitis? Well, out of 91 RCTs, they all showed that at least they have efficacy against placebo. All three failed to show any superiority of any one particular agent. There was a fourth review which looked at alcaftadine, which is only available in the States at the present time, and that was found to be superior to all three that are available in the UK at the present time. So treating allergic conjunctivitis, we've talked about avoidance, lubricants, cold compresses, lid hygiene, vasoconstrictors available on the open market, mast cell stabilizers and antihistamines used in combination. Decongestants are available as well on the market. Non-steroidals I generally don't use, so you could use topical ketorolac, but I find that it's got a well-known corneal side effect of causing ulcers because it only blocks one pathway of the inflammatory reaction. Therefore, it can deposit leukotrienes in the cornea, leading to deposits and then ulcers. So I would tend to avoid it if possible. It also stings as you apply it. The next is obviously steroids. Now, steroids are our mainstay. And although we don't use them as first line in allergic conditions, it may be necessary in vision-threatening conditions or in those conditions that we've not been able to control with other methods. Now, often in allergic conditions, they have an associated rhinitis as well in over 50% of cases. Doctors from ophthalmology often overlook that, but intranasal steroids have been shown to affect the ocular symptoms as well in a beneficial way. And if you see a patient with rhinitis, it may be useful for them to use intranasal steroids. Those can also, under monitoring, be used by children as well. You would follow them up in the clinic to check their intraocular pressure and state that there is a risk of cataract. But the risk of cataract is very low, used at the prescribed dose for a very short period of time, so 1 or 2 months. Obviously, we use steroids on the surface of the eye. Most of the evidence in the literature is for loteprednol, which is an ester type steroid, so therefore it's less prone to causing intraocular side effects like cataract and intraocular pressure rise. I would prefer to use Softacort myself, which is a preservative-free, because often these patients have got ocular surface issues due to the inflammation, and the preservative-free preparations are likely to be kinder. Don't forget the skin in those patients with atopic keratoconjunctivitis and contact blepharoconjunctivitis. It can be useful to use a very mild dose of steroids, so 0.1% steroid just on the periocular area to dampen down any inflammatory issues coming from the oculus, from the skin on the edge of the eyelid. There have been some RCTs using tacrolimus ointment, which can be used on the skin of people with atopic and contact blepharoconjunctivitis, but can also be used in the eye. And the evidence there has been for vernal keratoconjunctivitis. So in Japan, this is licensed for use in vernal. It's not licensed in the UK, but in those that are not responsive to other measures, tacrolimus can be useful for a short period of time. Recently, topical cyclosporin has been licensed for children over the age of 4 years old with vernal keratoconjunctivitis. It's basically the same preparation as Icavis, but used more often during the day. It can be useful in vernal keratoconjunctivitis. It can be useful in atopes, in which if you give it, it will either work very well or it won't work at all. But they can be very sensitive to cyclosporin use. So think of that in those patients. What do NICE say? Well, NICE say that the GP should advise the patients on non-pharmacological management, which we've talked about already, so avoidance techniques, cold compresses, ocular surface lubricants. They've said if non-pharmacological measures don't work, then they should prescribe a dual action mast cell stabilizer and antihistamine. But by far the commonest drug prescribed in primary care still remains chromoglycate, which, as we've seen, is useless for the acute symptoms. They should refer to secondary care for those patients with atopic disease, vernal disease, and giant papillary conjunctivitis to exclude vision-threatening conditions, and to allergy specialists for those with multi-system disease, so nasal, respiratory, skin conditions, or those in which they've got severe quality of life issues, which if you've seen anyone with atopic or vernal or perennial, it can really affect their schooling or their work situation. And this is a really dreadful condition for a lot of people. So in summary, atopic and vernal can be vision threatening, and you should have a low threshold for seeing those patients in the clinic, particularly if they've got pain. You need to think about the lids, particularly the upper lid, and avert the upper lid to look for the pathology there. Now that may be acute pathology like giant papillary changes, which may need dealing with, or it can be chronic issues like fibrosis, which can also affect the ocular surface. From the history, you need to find out if they've got an atopic history, so asthma, eczema, family history. You need to find out whether it's seasonal to work out what's the likely pathogenesis. You need to screen out those that are worrying, like new onset when they're older, symblepharon, if they've got pain, if they've got foreign body sensation, if they've got a purulent discharge. Try and identify the allergen using the tests we've described. So for contact blepharoconjunctivitis, patch testing is useful. For the others, skin prick test, followed by referral to immunologists for possible immunotherapy. Topical treatment can be useful for seasonal and perennial, but think about the immunotherapy. But atopes and vernal keratoconjunctivitis are likely to need systemic treatment and should be really a centre that can deal with those systemic treatments. Thank you. You're muted.
Okay, fine, good. Thank you very much, Damian. This is an amazing, comprehensive talk. I'm really glad that you covered the topics very nicely. You were going to details about the features in every subtype of allergic or ocular allergy disease, and also going through various modalities of treatment, which is amazing because there is so many options, but we don't know necessarily the path, how to treat those patients and where we start. Can I just ask you, we have a couple of questions here, but let me start with this question, starting with the diagnosis as well. Often people confuse, for example, allergic eye disease with dry eye disease. And also some people confuse MGD for allergic eye disease. So they treat this patient for MGD disease with all it takes, like a warm compress, etc., while actually that's just aggravate allergic eye disease. So what's your tips on differentiating those, please?
It can be very difficult. I mean, first to know is that, of course, people with atopy, they will also have dry eye disease as well, because we know that the atopy affects the meibomian glands. They will get an effect on the meibum produced by the meibomian glands, and they're going to have an evaporative dry eye condition. We know that seasonal allergic using interferometry is abnormal, and they will also have a dry eye condition as well, a sort of toxic dry eye condition. I think that seasonality is a helpful differentiator. It's, meibomian gland dysfunction, dry eye condition is generally not in the spring, summer months. They tend to get worse symptoms when the heating comes on and in the autumn in the UK. The signs are more at the eyelid margin in meibomian gland dysfunction. So you'll see a predominance of lid margin disease and associated skin conditions, which ophthalmologists often miss. So meibomian gland dysfunction is 85% blepharitis, secondary to either acne rosacea or seborrheic skin changes. So look for those. If they've got those, then it's going to push you more likely that it's meibomian gland dysfunction rather than an allergic issue. And itch. Itch is more common in allergy than it is in blepharitis. You can get it in blepharitis, but it's more likely in allergic. Mm-hmm. Why do they get it in blepharitis? Because you get the overgrowth of Demodex along the eyelid margin. That stimulates the allergic response because it's a parasite. So you get IgE, you get eosinophils. So you get the itchy response there. So you would expect that if you treated the Demodex with either ivermectin or the lid scrubs, you would get a decrease in the itch, and that would help differentiate. But yeah, it's looking at the whole package really.
Excellent.
So young people with itch is more likely to be allergic. Older person with itch, you've got to think maybe it's more likely to be the blepharitis and meibomian gland dysfunction.
Excellent. No, that's very important point, especially as you said, the itchiness. A lot of patients with dry eye complain about itchy eyes, and sometimes become difficult to differentiate. Are you talking about allergic eye disease or is it blepharitis? And also you mentioned something about Demodex, and you just said it now again, the role in allergic eye disease. So what makes you think this could be Demodex related? And you said ivermectin. Is that your main treatment, or you got other options?
What I meant is if you've got blepharitis, then it's more likely that the itch is caused by the Demodex, as opposed to a seasonal allergic or perennial allergic, in which it's going to be grass pollen, etc. Mm-hmm. I mean, I have in the past pulled out eyelashes and got the microscope out and looked for Demodex, staining it with, vision blue or fluorescein just to confirm. But the problem is that a lot of people have got a degree of Demodex, so it's working out what's an overgrowth or not. Yes, I would, if they've got, if I do the test, there's a lot of Demodex, they've got a lot of scurf and issues at the base of the lashes, then I'll give them a course of ivermectin, because it's simple, one-off tablet, and works very well in those that have got demodecosis.
Excellent, good. There's so many questions, so we haven't finished yet. I just want to, before we carry on the question, when we're moving to management now, just want to thank Thea. They're really, I'm sure Thea is very supportive to science and medical education and research in ocular surface. I would like to pass my thanks to them for supporting this webinar and many other webinars on the OSI in general. So thank you, Thea, very much, and always helpful when it comes to webinars and health medical education. So Damian, we're moving to management now. It is okay. A lot of, you said like in the UK alone now, and we have a lot of audience from UK and outside the UK as well. But in the UK, there's 18 million people probably suffer from ocular allergy. And I think maybe 17 million will end up having over-the-counter treatment. And that could sometimes mean delayed management. What do you comment on over-the-counter treatment? I mean, it's a lot of, you said, vasoconstrictive, for example, they come to you with this chronic red eyes, and they start to complain about cosmesis and how the eyes looks like, etc. Do you have any kind of, say, treatment pathway, so where the patient should just stick to the over-the-counter, and when do you think they should be referred to the ophthalmologist?
I think that in the UK, there's too tight control on a lot of pharmacy products, and you could safely have dual action mast cell stabilizers, antihistamines over the counter as a first line treatment, and lubricants, and a simple instruction to the pharmacist that they can hand those out over the counter. And that would help keep a lot of people in the community out of primary, secondary and tertiary care, and control them at a much earlier stage, so self-management. If they failed a dual action antihistamine and mast cell stabilizer, then I think that going to the general practitioner is generally unhelpful, because the pharmacists are able to provide the sort of avoidance techniques, and also the using cool compresses, etc., etc. And then after that, it's worthwhile going to secondary care, really, because you're going to need much more interventional treatments. So my own personal preference is that in the UK, the population is too protected and they need more over-the-counter products, not less.
Yeah. I mean, a lot of times the treatment is about symptomatic relief more than actually curing the disease.
Yeah.
What's your role in kind of your thought, I should say, in immunotherapy? I mean, you talked about it, and definitely there's a lot of randomized trial, and I think there's a lot of, I mean, I personally referred a few patients for treatment, but it's not cheap, number one, and it's not widely available.
Yeah, as a taxpayer, I don't want everyone who's got allergy to have immunotherapy, because we're going to be even more broke than leaving everyone off work on 80% wages.
Yeah.
But so I think that more over-the-counter preparations will sort of filter out those that have got more severe issues that we should prioritize for immune therapy. I think immune therapy is safe, and the problem is accessibility, because there are not enough immunologists really available in the UK that can provide the service. I think that they would quite quickly be swamped. So there needs to be a strategy in the UK for improving the allergy treatments, and also improving the immunology service in the UK before we can send large numbers of patients to them.
Yeah, I share that with you. And I mean, we both work in the same unit, and we see a lot of patients actually, especially atopic disease, where they pass the treating the active disease more than dealing with the complication and the damage already to ocular surface. Those end up with the cornea transplantation, and those are probably one of the most difficult to manage on a long term. Just a quick things. I've got a few questions from the attendees. Do you think anything role for the diet now? Do you think also some strict diets can really adversely or maybe opposite help the allergic eye disease?
I think that there probably is dietary issues. The evidence for that, I must say I'm not up to date with. But my own personal view is that a lot of these things are probably dietary related, either in early life or later on. I mean, some people their skin shows their sort of gastrointestinal allergic response. So particularly dairy products, sort of different carbohydrates that the body can't digest easily. Proteins that cause secondary effects on the skin. We see their effects in other conditions as well, like gluten hypersensitivity, etc. And they can easily be mixed up with those allergic issues as well. But I would be cautious about mentioning it, particularly in children, because then you can get a reactionary response from some parents in which they heavily restrict a child's diet, which equally cannot be useful.
Yeah, great. So I've got a question from Rajula asking, should ketotifen be started prior to the start of symptoms or once seasonal allergic conjunctivitis sets in?
That's a good question. Because it's got a dual effect, so it's got a more immediate effect from the histamine receptor antagonism, and it has the mast cell stabilizing effect. You can use it when the symptoms begin rather than as a preventative medication.
Okay, thank you. Question from Nicolina asking about experience with Relistat. Relistat. I haven't heard about before. Relistat. R-E-L-E-S-T-A-T.
I've never heard of it.
Okay, fine. Sorry, Nicolina. So I've got a question from Jesus Alvarez. Do you have experience with leaflet grass and how to use?
Well, it's only available in the US. So I've not used it in the UK. It's not licensed in the UK. It's LFA1 blocker, I think. So I don't think it would be useful in allergy. Maybe useful in dry eye.
Amazing. Right. So we got Muhammad Muhiddin asking, how long can you keep children on Verkesia? I just talked about Verkesia in vernal disease. So the question, how long you keep them on Verkesia? And can you taper down to twice a day if symptoms are settled?
Sorry, to go back to the previous question, Relistat is epinastine, which yes, I have used actually,
okay.
and I think it's I've only used it in 1 or 2 patients, but it's very good. One of our well-known patients, I think if I could say Sarah, it's been on this for many years.
Okay.
And well tolerated, and I think it's a good medication. Sorry, the next question was about
Verkesia, because I think Verkesia recommended 4 times a day during the season. Yeah. But the question was, do you then taper it off to twice a day if symptoms are settled?
No, I think it's to be used either 4 times a day or not used at all, due to the mechanism of action. So it's not like steroids. You don't taper it down. It's not a steroid. So I would use it 4 times a day when you've got the condition, and when you haven't got the condition, then I stop it. I mean, often the concern is with these things, does it have any systemic absorption, etc.? So you're going to get worries from the parents, etc., because they'll have read online that their kid is going to get hair growing out their ears and their gums are going to bleed, and then their kidneys are not going to work. And there's no evidence of that. So it's about reassuring the parents, using it for as short a time as possible. And I think it's a good medication for its indication. Yeah,
excellent. I mean, I'm glad you mentioned that. It's not like tapering off like a steroid. And I think the study, the Victor study showed that twice a day, it probably works as good as 4 times a day, but it's not the same strength of efficacy. So yes, great. So next question from Polo C. What's your opinion on ectoine as an active ingredient in Hydrodual in allergic conjunctivitis? The role of ectoine.
Ectoine?
Yeah.
I don't know about the role of ectoine.
Okay, fine. It's just to help the ocular surface. Next is a question from Nicolina again. So, say patient with AKC and recurrent corneal erosions, would you recommend stromal puncture? If someone with the AKC and recurrent corneal erosions, would you recommend stromal puncture?
Well, I would wonder what's causing those recurrent corneal erosions, really. I can't think that I've seen somebody with atopic and like a basement membrane dystrophy issue. I would wonder whether the recurrent erosion was more mechanical. So I would take a long, hard look at the eyelid to see whether it was in the normal position or whether it was rotated. I would look on the underside of the eyelid. I would look to see whether there's fibrosis or follicles that were causing a mechanical issue with the epithelium. If I excluded all of that, I think that as long as it wasn't in a visually significant area, then I may consider that. But I would look for a lot of other causes first before I did that.
Excellent. Damian, thank you so much. I think this is an amazing and comprehensive cover for a very important topic. And I think you just highlighted how popular this condition is and we probably see it every day in our practice. And certainly you enrich our knowledge, and both on the basic level and on the most advanced therapies. So really great to you to talk this today. Thank you so much, Damian. And hopefully see you again in the OSI webinars. I just want to say thanks to the audience, thanks Thea. I just want to remind the audience that on the 9th of July, we have a very special webinar. This is a bit of a twist of the usual webinars. This is about the eye health and how to ensure safety and beauty. So we really want to cover topics related to invasive and non-invasive cosmetic treatments, how it affects the ocular surface and how to avoid ocular surface compromise from those, from something simple like eye makeup to more invasive like plastic surgery, Botox, fillers, etc. And I'm privileged to have two excellent speakers, Sabrina Shahdizai, aesthetic ophthalmic plastic reconstructive surgeon, and Amy Gallen-Sullivan, who had done a lot of work. She co-founder of Tifos News, and amazing speaker. She talked a lot about eye makeups and the effect on ocular surface. Remind you that Ocular Surface Insight is here to help you, to help expand the information, knowledge, especially related to ocular surface. As you can see, we run the webinars. We have the magazine, which founded 3 years ago, and it's quarterly magazine. We welcome your contribution with topics you find is useful to other colleagues. So I hope you find today useful, and OSI webinars will continue, and I hope to see you again on the 9th of July. Thank you very much for everyone to stay at the end. Thanks, Thea. Thanks, Damian. And thanks, OSI team. Great work as usual, and hope to see you again next time. And good night.